Good morning, all. Today we'll be speaking about a 50-year-old male who was presented with abdominal distension and jaundice. But before that, we'll start with an overview of the Center for Digestive Sciences, which was actually a brainchild of our emeritus chairperson, Dr. M.L. Swarankar. And the idea was to have all the collaborating and interrelated departments work together, and we project ourselves as a center for digestive sciences. So it includes hepatopancreatobiliary surgery and liver transplantation, surgical gastroenterology, medical gastroenterology, and hepatology. Today we are going to present this case from the Department of Hepatopancreatobiliary Surgery and Liver Transplantation. Now, when we talk about HPB surgery, this is relatively a very new branch which has now officially come up, though we used to practice 20-25 years ago as HPB surgery, but as general surgeons we used to do somebody who is more interested in HPB surgery. But today NMC has now recognized this as a separate branch, and it deals with surgery of liver, gallbladder, bile duct and pancreas. So what all it includes is liver resections. In our unit and department also we perform liver resections. Pancreatic surgery, not just limited to Whipple's. Whipple's is very famous, that pancreas means Whipple's, but there are a lot of other pancreatic surgeries. Distal pancreatectomy, ramps, we do pancreatic necrosectomies, cystogastrostomies. All the HPB cancers, CAGB, liver and pancreatic cancers, NET, they all come under the purview of HPB. Fortunately, we are one of the referral centers for bile duct injury, and at our department we have started a program where all those patients, we have received about 40 patients of bile duct injury referred to our department, and we give a feedback to the operating surgeon. Those surgeons who are willing to be part of that feedback, about 13 have agreed to be part of that feedback, and we do take them through the whole surgical process, emphasize the importance of critical view of safety. And this is the idea here is not to demean the surgeon who is operating, but the idea here is to teach and avoid any further injuries which may happen later on. And there are 13 surgeons who have been part of it and were willing to take that feedback. Apart from HPV surgeries, we also give a helping hand to our ancillary surgical branches, whether it be a IVC tumor or a large renal cell carcinoma or an adrenal tumor which is pushing or infiltrating into the liver. We perform these cases laparoscopically, as well as in complex cases we do open, whether it be adult or pediatric. So we have done that in all age group. Apart from the clinical side, when we come to the academics, as I said, HPB surgery is a newer branch now, and we are one of the 3 centers in the country which is offering MCh HPB surgery. We have currently a single student year uptake in every year, so we have got 3 residents who are now pursuing MCh in HPB surgery. In terms of liver transplant, we are performing the numbers as second highest in the country in a medical college. The faculty is associated and on board of as a specialist board member of liver transplantation in National Board of Medical Examination. Have been executive member in the Indian Association of Surgical Gastroenterology, currently a scientific chairman at the Indian chapter of International Hepatopancreatobiliary Association, and have been associated with the Liver Transplant Society of India as well. So here we just wanted to show short videos of a laparoscopic liver resection in an early cirrhotic liver where there is a tumor which was visible. And there you can see that's the tumor which is now visible. We also have these instruments again provided with the courtesy of the whole management. We have got laparoscopic staplers which we can fire on the pedicle. So that's a stapler now being fired. We need to take care we don't get the hemolock in the view when we are firing the stapler. You can see the stapler moving. The line will be firing, and all those who have my surgical colleagues have used will know what we are talking about. And we also have, this is a CUSA which is utilized in liver resection. We also have the laparoscopic CUSA where not many centers have only CUSA. We have an additional on it, it's a laparoscopic probe, so we are able to do liver resection laparoscopically. And then once the resection is complete, it will be removed. Coming to the other case is laparoscopic partial pericystectomy, again that is being done, but we prefer doing it in complex cases which are referred to us depending on the location of the tumor. As you can see that the tumor is located and touching and abutting the diaphragm. There it is touching the diaphragm. So in these cases sometimes it becomes difficult. This is the distal pancreatectomy. There is a tumor in the tail of the pancreas. The whole pancreas is now lifted off. You can see the splenic vein has come into your view. That is the splenic vein which is seen here. And then that's the splenic artery now which is being dissected off the pancreas. This is a large RCC with an IVC tumor. We have looped, if you can see that's the tumor. We have looped, taking an incision on the inferior vena cava. There will be significant amount of bleeding. As you can see, we have taken an incision on inferior vena cava. We have looped the right renal vein, left renal vein, distal IVC, proximal IVC and suprahepatic IVC as well. And there, as you can see, initial clots do come out, and then we are trying to remove the tumor thrombus. That is the large tumor thrombus now which is coming out. And once that is removed, we cut that out and suture the IVC again. The activities done over the last few months is we have conducted the first HPB masterclass and cadaveric organ retrieval workshop in the state of Rajasthan, where we had participants coming from all over the country. SOTO had requested us to include some of the participants from non-transplant organ retrieval centers. So we had got surgeons from Jhalawar who wanted to be part of the NTORC program by SOTO, and now they are trained to retrieve the organs. So this was the masterclass first ever done, and organ retrieval cadaveric course first ever held in the state of Rajasthan. We had eminent faculties coming from all over the country with didactic lectures. This is the cadaver dissection. We are thankful to the Department of Anatomy who had provided us with the cadaver and the dissection hall. Dr. Pankaj is here in one of the photographs. And here the participants, we kept only 3 participants per cadaver. They were told how to retrieve, and they were taught how to retrieve, including the instrumentations, the use of staplers. That was again re-emphasized during this class. Emeritus Chairperson Dr. M.L. Sorankar was kind enough to distribute the certificates during this course to all the participants. Coming to the conferences we have been part of as faculty, we have had invited talks in international and national conferences as well. This is the European Society of Organ Transplant and International Pediatric Transplant Association, where we had delivered a talk. This is an international Indian Association of Surgical Gastroenterology, the national meeting. This was the Asia Pacific Hepatobiliary Association, where we had delivered a talk, and this is the Korean Society of Endoscopic and Robotic Surgeon, again last year, where our faculty had given their specific talks. Coming to publications which had gone out from this department, we have one of my students had done the analysis between a single loop reconstruction and an isolated loop reconstruction, which was published in Pancreatology. We had done transplants, and in our department 70% of our transplant were done in public-private partnership, where we had done under the government schemes, which was again found publication in International Journal of Gastroenterology. We had also written a review article on pancreas transplant. So this is just an overview of transplant program at Mahatma Gandhi Medical College and Hospital, where I was fortunate to be part of the program since 2018. And I take pride in this, that today with the thrust, the emphasis, the vision of the Emeritus Chairperson Dr. M.L. Swarankar, and under the able leadership of Dr. Vikas Swarankar, and the support from the whole MGUMST University, the faculty, we have crossed 100 liver transplants, which is an achievement in the state of Rajasthan. We are one of the first. We are the first in this state to reach this landmark, and it is not the end. We are still going to continue. This is the etiology we are seeing instead of Hep B and Hep C, which was the main etiology over the last decade. Now we are seeing more and more patients coming with alcoholic liver disease and non-alcoholic, or now being called as metabolic associated fatty liver disease. Now when we talk about the number of transplants, we also need to specify what is the outcome. Nobody asks what is the outcome, but outcome is equally important. So at our center, we are fortunate enough, with God's grace, we have been able to reach a percentage number of 91%, which is the survival rate, which is equal or more than any other center worldwide. Some of our achievements have found their way. We are lucky to perform the first pediatric transplant, the first acute liver failure transplant, and there are many more firsts which we have done, and we'll be speaking about it, and which is fortunately it has found its way in the publications of the newspapers. I would now like to call my senior resident, Dr. Manmohan Singh, to take us through with the case, please. Dr. Manmohan.
Thank you, sir. Good morning, respected teachers and dear colleagues. So, I'm Dr. Manmohan Singh Rajput. I'm final year MCh HPB resident in the Department of HPB Surgery and Liver Transplant. So, we shall be discussing a case of a 50-year-old male who presented with jaundice and abdominal distension. So, let's get started. So, a 50-year-old gentleman who was a farmer by occupation came with progressive yellowish discoloration of eyes and urine for a period of 1 month, and progressive abdominal distension, which initially started at the flanks and then progressed to the whole abdomen for a period of 1 month. The patient also gave a history of decreased urine output for the last 3 days. Patient, however, did not give any history of abdominal pain, nausea, vomiting, hematemesis or melena, altered mentation, altered sleep, or slurred speech. There was no history of pruritus or pale colored stools, no history of fever or prodrome, no history of cough or shortness of breath, no history of blood transfusion, no history of consumption of hepatotoxic drugs or consumption of any alternative medications, and there were no similar episodes in the past. The patient did not have any comorbidities. He, however, consumed alcohol about 180 ml at least 3 times a week, equivalent to around 60 grams of alcohol, for the last 10 years. Last intake was 6 months back, and he was a non-smoker. Summarizing the history, a 50-year-old male, alcohol use disorder, presented with paleness, progressive jaundice and abdominal distension, decreased urine output with no GI bleed or prodromal symptoms. So what could be the possible diagnosis? Anyone? So yes, moving ahead. Since the primary symptoms were jaundice and ascites, the causes can be broadly categorized into 3 categories: infective, malignant, and benign. So the infective causes can be viral hepatitis, complicated malaria, leptospirosis, and tuberculosis. The malignant causes can be GI malignancies with liver or peritoneal metastasis. The other possibility is lymphoma, and the benign cause can be decompensated chronic liver disease. Coming to the general examination, the patient was conscious oriented to time, place and person, lying comfortably in the supine position with a ECOG of 1. His height was 170 centimeters, weight of 126 kgs, with a BMI of 43.5 kg per meter square. Pulse rate was 88 beats per minute. Blood pressure was 130 by 80 millimeters of mercury in right arm supine position. He maintained a saturation of 98% on room air. Icterus was present. Bilateral pedal edema was noted. There was no cyanosis, clubbing, or generalized lymphadenopathy, and there was no stigmata of chronic liver failure. Coming to per abdomen examination, on inspection, the abdomen appeared distended with a central and transversely stretched umbilicus. No dilated veins, scars, or sinuses were noted. On superficial palpation, there was no local rise of temperature and no tenderness. However, on deep palpation, a firm, nodular, non-tender liver was felt 2 centimeters below the right costal margin in the mid-clavicular line, and the spleen was felt 3 centimeters below the left costal margin, which was non-tender. Here the diagrammatic representation of the liver spleen is shown. Coming to the percussion, the liver span was 16 centimeter, which started in the right fifth intercostal space, and on percussion we elicit a sign called the fluid thrill. I would like to pose another question: at what volume of fluid within the abdomen is fluid thrill usually positive? If anyone could answer. Yes, please. Yes, you're in the ballpark. So around a volume of 1000 to 1500 ml will give a positive sign of fluid thrill. Shifting dullness is usually positive above 500 ml. The USG and the CT can diagnose abdominal cavity fluid of around 50 ml or less. Bowel sounds on auscultation were normal. There was no venous hum or arterial bruit. PR examination, anal toll was normal, and on the examining finger, colic stools were noted. Coming to systemic examination, the cardiovascular system, normal S1, S2 were heard, no audible murmur. Decreased air entry was noted in the light lower chest. However, there were no crepitations or rhonchi. No neurological deficit was noted. Now taking a look at the investigations, on hemogram, we could see the hemoglobin was 7.3 grams per deciliter. The total leukocyte count was 3,600 and platelets of 44,000, suggestive of pancytopenia. The RFT was, the urea and creat were essentially normal, and hyponatremia was noted. Looking at the LFT.
Excuse me, may I interrupt? Can you go back one slide?
Yes, sir.
So whenever you have a patient with significant anemia, then you must, along with the hemoglobin, mention the RBC indices.
Right, sir.
Right?
Right, sir.
What implications that has, that is a separate issue, but they must be mentioned if there is significant anemia.
Yes.
Right?
Sure, sir.
Whether it's a surgical presentation or a medical presentation, that minimum has to be there.
Yes, sir. Right, sir. Looking at the LFTs, the total bilirubin was 5.9, direct being 3.9. The INR was elevated, which was 3.19 seconds, suggestive of coagulopathy. Albumin was low, 2.8. Viral markers were negative, and the chest X-ray suggestive of light pleural effusion. Looking at the ultrasound abdomen, the major findings were that the liver showed a coarse ecotexture with surface nodularity. The portal vein was 14.5 mm, which was more than the normal diameter. The spleen was enlarged, so was the splenic vein, 13 mm, and there was free fluid noted in all quadrants of the abdomen. Since the investigation in clinical history was suggestive that the patient had chronic liver disease, we targeted further investigations in that direction. We went ahead and did an upper GI endoscopy, which showed antral gastritis. However, no esophageal or gastric varices were noted. Fibroscan could not be performed because of the obese build and tense ascites. We did a diagnostic ascitic tap, which showed no malignant cells, low ADA, and a serum ascitic albumin gradient of 2.1, suggestive of a transudative etiology. We did an autoimmune workup, which was negative for this patient. We did a contrast-enhanced triple-phase CT. The major findings were gross ascites, nodular liver, no focal arterial enhancing lesion. Other than that, portal vein was prominent, spleen was enlarged, and there were perisplenic collaterals. Now, with the history, examination, investigations being done, we can now summarize that a 50-year-old male who was morbidly obese, alcohol use disorder with jaundice and ascites. On examination, there was icterus, there was gross ascites, there was a palpable nodular liver, and a palpable spleen. Investigations were suggestive of pancytopenia, deranged LFTs, coagulopathy, hyponatremia, and the radiological assessment was suggestive of chronic liver disease. So now, we had looked at the three categories which could be responsible for this sort of a presentation. We can now rule out infective, malignant, and the benign cause remains, which is decompensated chronic liver disease. I would now like to invite Dr. Karan to shed some light on it. Thank you.
So good morning, everyone. So now we have a morbidly obese man with a BMI of 43 who had got decompensated chronic liver disease or decompensated cirrhosis. So how to approach or manage this patient? So management of any patient with decompensated chronic liver disease stands on 4 pillars. The first one is treat the etiology. Whatever is the cause of liver disease, treat that cause. If a patient is having alcohol-related liver disease, stop alcohol. If it is obesity, ask patient to lose weight. If it is related to some chronic hepatitis viruses like B and C, treat those viruses. So treat the underlying cause which has led to chronic liver disease. Second is treat the symptoms or the complication. Like this patient had got ascites. We have to treat his ascites to make him comfortable. For treating ascites, restrict his salt, add diuretic to make him pass urine, give albumin, and again some if he's also having encephalopathy, or give lactulose to prevent development of encephalopathy. Third pillar is to treat the portal hypertension. If a patient has got varices or variceal bleed, do an endoscopy and ligate those varices and start him on beta blockers. And the most undermined part of the management is nutrition. In a patient with chronic liver disease, the most important aspect is nutrition. The patient should be fed. It's an old belief that a patient who is having jaundice, restrict his food, put him on boiled vegetables, don't give him oil. All this is not right. The patient with cirrhosis who is having jaundice, they require more calories. In fact, the calorie requirement for them is around 35 kilocalories per kg per day, and protein requirement for them should be around 1.2 to 1.5 gram per kg per day, which is slightly more than what is required by average healthy human being. Apart from that, every cirrhotic patient should be screened for development of liver cancer, that is the hepatocellular carcinoma. Like in this patient, we performed this CT specifically to look for any focal arterial enhancing lesion which was not found to be there. So this is regarding the medical management. We start the patients on management. The question remains, the patient asks how long I can continue on this management. What next? I am only 53-year-old. Can I pull through my life with this management, or I need something else? To answer this question, we have to just take a break and look at what is the natural history of chronic liver disease.
Can I intervene? Can you go back a slide?
Yes, sir.
So for this particular patient, if you do the follow the issues in point number 1,
yes, sir.
Will his chronic liver disease reverse?
So that is, I am coming to this thing in the what will happen if we will continue with this management. So coming to the natural history of chronic liver disease, cirrhosis has got 2 parts. One is compensated cirrhosis. Compensated means if you do an ultrasound, you will find a shrunken liver. If you do a CT, you will find a shrunken liver. In fibroscan, the stiffness of liver will be increased. But if you do the LFTs, they will be bang normal. Normal bilirubin, normal, and patient will have no symptoms. That stage, which can be detected only in the phase of imaging, that is known as compensated cirrhosis. In those compensated patients, if you will treat the etiology, now there is a possibility that they can reverse back and can become normal, though very little percentage, but that can become normal. If the cirrhotic patient has any of the complication, either jaundice, ascites, encephalopathy or variceal hemorrhage, they transit into a stage of decompensation. So our patient already has developed ascites, so it is basically a stage of decompensated rather than a compensated. In that stage, reversal is usually not possible. So how many patients will transit from this compensated to decompensated stage? If not treated, 5 to 7% of patients, means 1 out of every 15 patients who is having compensated cirrhosis will transit into a decompensated stage every year. So among these, out of those 4 complications I have listed, the most common and the first complication which is usually seen is the ascites. So what happens when a patient transits from compensated to decompensated stage? As you can see that it was a very beautiful study by Perry Gaines in which they have shown that natural history of cirrhotic patient, once they transit from compensated to decompensated stage, the survival reduces drastically from 9 years to 1.6 years. That is the patient who is having compensated cirrhosis who was about having median survival of 9 years, the survival decreased to 1.6 years. So that is again a median survival thing. So how to objectively quantify, tell the patient, what are your chances of having, surviving the next 3 months or a year? To objectively quantify that, we have got now devised 2 scores. One is the CTP score, Child Turco-Puke score, which is dependent upon 5 parameters: encephalopathy, ascites, bilirubin, albumin, and prothrombin time with this internationalized normalized ratio. Our patient doesn't have ascites. He had a moderate ascites with a bilirubin of 5, which is more than 3, albumin which was less than 2.8, and INR which was more than 2.2. 3. If we calculate this CTP score for our patient, it comes to be around 12. And with this a score of 12, the 1-year mortality for such a group is more than 40%. That is, he can die with, there is a 40% probability that this patient will not survive more than a year. To go back, even the short-term survival, what will happen in the next few months, there is a new other score which is the model of end-stage liver disease score, the MELD score. It is based on 3 parameters, bilirubin, INR and creatinine. And there is an online calculator available for this score. You just enter the value for the patient and you will get a number. That number will tell you what is his 3-month survival for this patient. Like our patients had a creatinine of 0.7, bilirubin of 5.9, INR of 3. When we put the value in the calculator, his MELD scores come out to be around 25, which is putting him at 3 months mortality risk of around 19.6%. That is, 1 out of 5 patients will die within 3 months. So final diagnosis will be he is a decompensated chronic liver disease patient due to alcohol use with decompensation in form of jaundice, ascites and coagulopathy, and he also had got a right side pleural effusion which is probably hepatic hydrothorax. His severity scores come out to be CTP score of 12 and MELD of 25. So now we have got the disease, we have got the prognosis. There is a 20% probability that he will not survive for more than 3 months. So what next? So we will continue the patient on medical management, the diet, the nutrition, beta blockers, diuretics, but the definitive cure, he doesn't want to live for 3 months, he wants to live for 20 years, hale and healthy. For that, the definitive cure will remain only liver transplant. So we offered them liver transplant, and to take the journey for liver transplant, I would like to invite back Dr. Manmohan to take the case forward. Thank you.
Thank you, sir. So moving ahead, after this discussion, we had determined that the liver transplant was the only curative option for this particular patient. So we shall now take a look at, if at all we want to start the proceedings for liver transplant, what would be the source of the donor organ? So there are 2 possibilities, either a cadaver donor from a brain dead individual or a partial graft from a living donor liver transplant. Due to the abysmally low deceased organ donation rates in India, which are 0.52 per million, finding a cadaver donor is difficult. The usual wait list is around 2.5 years, and the mortality during this wait list is 30 to 40%. During this course, the patient may require multiple hospital admissions, which causes an increased resource burden, both economically as well as socially, on the patient and the family of the patient. So now that we have decided to go ahead with a living donor liver transplant, what is the donor selection criteria? The donor should be a near family relative, 18 to 55 years of age, and blood group matching is done. So by near relative, I imply the wife, brother or sister, children, parents, grandparents and grandchildren. The patient's wife in this case was evaluated with routine tests. I would like to here explain the fact that 2% of the body weight is the usual normal liver volume, and out of which 40%, a minimum of 40% is required for adequate function. Therefore, the minimum required donor graft volume is 0.8%, which is actually 40% of the normal liver volume. This is what is termed as graft recipient weight ratio. This volumetry is calculated on CT scan. I would now like to invite Dr. Jai Choudhary from the Department of Radiodiagnosis to explain this. Thank you.
Good morning, respected sir and everyone. So today we'll be discussing about the role of radiology in live donor liver transplantation. So radiology has got very important role at each and every step, starting from the donor assessment to the post-operative complications. First of all, we do the CT liver volumetry, in which we calculate the total liver volume and the right and the left lobe volumes. Then we evaluate the vascular anatomy by the triple phase contrast enhanced CT scan of the whole abdomen. Then biliary anatomy is assessed by MRCP. All this is done to see any variants in the vascular anatomy or the biliary anatomy. Then during the surgery, after the portal vein and hepatic artery are anastomosed, then intraoperative Doppler is done to assess the patency of the hepatic artery and the portal vein. Then the portal vein flow volume is calculated and hepatic artery RI is assessed. This is absolutely necessary because the most dreaded complication of liver transplant is hepatic artery thrombosis. So if we find thrombosis in intraoperative, then the surgeon will have to redo the artery. Then from next day onwards, twice a day post-operative Doppler is done, and if there is any post-transplant complication, which is fortunately very less in our institution, then radiology helps in the imaging of the post-transplant complications. So steps of liver volumetry: first of all, on non-contrast CT scan we calculate the liver attenuation index, then a triple phase CECT is done, and post-processing is done on the Advantage window software. Liver attenuation index, it is done for the estimation of significant hepatic steatosis. What happens is, it is based on the fact that if in any organ of the tissue fat is increased, then that organ will appear dark. So normally what happens on a non-contrast CT scan is that liver is brighter than the spleen, and HU value of normal liver is about 8 to 10 more than the spleen, and normal liver HU is between 50 to 65. In liver attenuation index, we take HU value of liver and spleen at multiple levels. At multiple levels, the HU value is calculated, and then the mean is taken. And in spleen also, the HU value is calculated and the mean is taken. And liver attenuation index is mean HU value of liver minus mean HU value of spleen. So the normal value is more than +5. It indicates that there is absence of significant macrovascular steatosis. There is less than total liver volume, less than 6% is fat. And if it is between -10 to +5, then we label it as mild to moderate hepatic steatosis. Out of total liver volume, 6 to 30% of fat in liver. And if it is less than -10, then it is moderate to severe, more than or equal to 30% fat in liver. The importance of this is that if in our institution, what we follow, if liver attenuation index is less than 0, that if it is in negative, then that donor is not taken for the transplant. And if it is between 0 and 5, then liver biopsy is done. So after if the liver attenuation index is normal, then we go for the triple phase CT scan. Then this CT angiography is done for assessment of the arterial anatomy. So here we can see a CT angiography of the abdomen. This is the right hepatic artery. This is the left hepatic artery, and this is the gastroduodenal artery. If any normal variant, if any abnormal variant is there or variant anatomy is there, then we can tell the surgeon in advance. So these are the images of the vascular portal venous and hepatic venous anatomy. This is the main portal vein. This is the right portal vein. This is the left portal vein. This is the right hepatic vein draining into the IVC. These are the colored images of the same. So in volumetry, what parameters are calculated? We calculate the total liver volume, then right lobe volume without middle hepatic vein, and left lobe volume with middle hepatic vein. The logic behind this is that when we take out the right lobe of the liver in adult liver transplant, so the remnant liver volume, what amount of liver should be left behind, is minimum 30% of remnant volume is required for the donor to survive. For example, if the liver volume is 1000 cc, so after taking out the right lobe, minimum 300 cc should be left behind in the donor. So after a triple phase CT scan is done, we do, by the paintbrush technique, we separate the entire liver parenchyma from the rest of the body. The extra hepatic vessels, the gallbladder and the IVC are excluded from the liver volume, and this is the right hepatic vein, this is the middle hepatic vein, and this is the left hepatic vein. the middle hepatic vein is taken as the landmark, and the cut plane extends from the middle hepatic vein to the gallbladder fossa. So this is the right lobe liver volume excluding the middle hepatic vein. This is of our patient only. This is the left lobe volume including middle hepatic vein. These are the some representative images. What kind of images we can create? This is the segmental anatomy of liver, color coded. Then again these kind of images. Then this is the right hepatic vein, and we can see the variant here. These are not of our patient. These are only the representative images. How beautifully we can depict the anatomy in. This is also the same. This is the right lobe, color coded. This is the left lobe, color coded, and then we are in the surface rendered images. So advances in volumetry. What we do right now is the volumetry takes around 1 to 1.5 hours, because we have to trace the entire liver volume. Then dedicated one-touch softwares are available, like Miriam. These softwares are very expensive, costing around 30 to 35 lakhs. But that will really help us in. So I would request sir to sir, नहीं सर, इसीलिए सर.
No, we will get it done.
Sir, thank you.
I'll tell that it should come within a week or so, as early as possible.
Sir, thank you. So all these softwares are very quick and accurate, but added consideration is always there. So this was in short about the liver volumetry. Currently in our department, 3 MD students are pursuing their thesis on topics of liver transplantation, sir. Now I would like to call Dr. Anand to take our case further. Thank you.
Thank you, sir. Good morning, everyone. Regarding this case, as Dr. Karan discussed earlier, with the medical treatment, patient reduced his weight from 126 kg to 107. As Dr. Manmohan discussed previously, the required volume for this patient is around 856 gram. And as his wife was evaluated for this donation, so the wife was found to have volume of around 582 gram, which was not an ideal GRWR for this patient. So family was informed and counseled regarding the need for the other donor in the family to get an adequate volume in the donor. So as I know, as I told you, the volume which was the wife having was insufficient for the recipient. We call this as insufficient size graft or the small size graft. These have a problem of small for size syndrome. It causes increased mortality and graft failure in the form of hyperbilirubinemia, severe ascites, and the coagulopathy. So the treatment options in our patient, medical treatment, Dr. Karan has said previously, this is not a feasible option for this patient. Now the cadaver list, we have to wait for around 2 to 3 years to get a cadaver. So this is also not a feasible option. Now other option is go ahead with a partial liver graft from single donor. But we have discussed the wife has an insufficient graft volume, and search for the alternate donor in the family, which was explained to the relative, which was not available in the family. So the option comes to in our patient 2 donors from the family. So the getting 2 graft from the 2 donors. So this is the final we have explained to the family. So regarding what is a single donor liver transplant, the complexity of the single donor liver transplant, it involves harvesting of the graft from the donor, which require dividing the vessels and the bile duct, and these vessels and the bile duct anastomose done in the recipient. As you can see in the image, the hepatic vein, portal vein, and the bile duct and the artery was anastomosed. It is a difficult procedure, and now you can think this procedure is done in the dual lobe, which is technically more challenging and complex surgery. So the other donor was evaluated in the family. As we have discussed, wife was evaluated initially with volume of 582 gram, and the brother's wife was also evaluated. The volume was around 289 gram. This evaluation process we do simultaneously in the donors, and the total graft volume is 871 gram. So it is feasible for us give the demand of the patient. So it is the right volume we can have in our patient. So the decision was to make that we take a 2 graft from the 2 donors, one from the wife, another from the brother's wife, and it will meet the metabolic demand of the recipient. Brother's wife, because he was we always evaluate the donor's family. So this is a dual lobe transplant. It involves 6 procedures: 2 donor operation, 2 bench operation, and the 2 implantation in the recipient. Now coming to the how we did this procedure: right lobe from the wife, left lobe from the brother's wife, and it will make the complete graft. It's a pictorial diagram, and this is the original diagram taken from intraoperatively, how it can look right lobe and the left lobe. I want to show you the small video of this procedure. In this procedure, you can see the right hepatic vein is anastomosed to the IVC, inferior vena cava. The white structure you are seeing, this is a graft which is anastomosed to the right hepatic vein. So the common opening. After that, the portal vein is anastomosed to the right portal vein, and lastly the right hepatic artery's anastomosis was done. This is the right graft. After that, this is a benching procedure of the left graft, and this left graft is also anastomosed to the IVC, followed by portal vein. Then this is the portal vein, and you can see this is right hepatic artery, and this is a complete graft, right lobe. This is right lobe, and the other side you can see this is left lobe, and you can see the anatomy here showing right hepatic artery, right portal vein, and another side is the left hepatic artery and left portal vein. So this cumbersome job took us to around 18 hours to be used in the complete procedure, and the 6th procedure was performed simultaneously, and 3 OTs were running simultaneously. The whole procedure required around 1000 ml blood, and 3 units of PRBs was transfused. Recipient was wheeled out of operation theatre in hemodynamically stable condition, and for completing this job we required more than 40 personnel in the theatre. Yes, sir.
So I thought I remembered that this patient had hypersplenism and a platelet count of 50,000.
Yes, sir.
So is that not an issue with a supra-major surgery like this?
No, sir. So what we do, this low platelet, we do take thromboelastogram. If the take suggests we see intraoperatively how the patient is behaving. Is it bleeding or not? If he bleeds, then we transfuse the blood product in the form of FFP and platelet or SDP we give. This is the photo of our department with the patient, recipient with 2 happy donors, and this is the last follow-up of our patient.
मेरा लीवर ट्रांसप्लांट 20 जनवरी 2024 में महात्मा गांधी हॉस्पिटल जयपुर हुआ है। मैं अब बिल्कुल पूरी तरह से स्वस्थ हूँ और मुझे 2 लीवरों की जरूरत पड़ी थी क्योंकि मेरा बॉडी वेट काफ़ी ज़्यादा था, इसलिए एक व्यक्ति का लीवर सफिशिएंट नहीं था, इसलिए मेरी पत्नी और मेरी भाभी ने मुझे लीवर दिया और दोनों ही के लीवर लगे। डॉक्टर निवेश एन मेहता और उनकी टीम ने सक्सेसफुली ऑपरेशन को अंजाम दिया। अब 16 जून 2024 में हम बिल्कुल स्वस्थ हैं तीनों और अपने दैनिक कार्य स्वयं करते हैं।
For the further discussion, I would like to invite Dr. Nimesh Mehta, sir. Thank you, sir. Thank you, sir.
So just answering sir's question, what he was asking, why platelet count. So we normally, all these patients whom we operate, we do transplant, they have got severe coagulopathy. and liver is the major organ which actually produces the clotting factors. Unless we rectify that, there is no way you can move forward. So we have to monitor, as my colleague has already pointed out, we monitor and accordingly we give the transfusions. There is sometimes significant blood loss involved because of the coagulopathy and the portal hypertension, the collaterals. So, but we still have to go ahead and we do manage. Why we selected this case? There is a rising now MAFLD, that is metabolic associated fatty liver disease. We are seeing rising number of these cases. Last week itself we celebrated a global fatty liver day. So that was one of the major reasons. This gentleman was 126 kilos where a single graft was not sufficient. This case was an ideal, or I would say a torchbearer of a complex case where the treatment was offered by a multidisciplinary team approach. What do we mean by team is basically together everyone achieves more, and that is what I think at MGUH we have seen and shown that. This was the most complex surgical procedure, as my colleague has already pointed out. Doing a single lobe liver transplant itself is so difficult. In these cases where you have to put two livers in and do the same procedure over again, it's technically much more challenging. There are very few centers worldwide which actually performs this type of dual lobe liver transplant, and I can proudly say that we are probably the second largest number individually where I have performed more dual lobe liver transplant in this country. There is only another single center which does more than us, and this being the first dual lobe liver transplant of the state of Rajasthan. That was the reason why we selected this case for the CCR. And with the vision of our emeritus chairperson, the thrust, the emphasis and the support given by the chairperson Dr. Vikas sir, we were able to achieve 100 liver transplant in a very short period of time. So I would like to acknowledge Dr. M.L. Swarunkar sir, emeritus chairperson, Dr. Vikas Swarunkar, who is the chairperson, the whole administration of MGUMST, specifically to the CCR review team who has been relentlessly reviewing our presentation over the weekend. A big shout out to the Department of Anesthesiology, because as I said, single lobe transplant, managing the case, single implantation, it is very difficult. When we have done a simultaneous dual lobe transplant, our anesthetists have been fantastic and have been holding fort. The Department of Hepatology, a blood bank and transfusion medicine who has always stood by of whatever demand, though in this case we had used only 3 units, but many a times we do exceed 10 to 12 or 15 units and they have never ever complained. So a big shout out to them as well. Department of Radiology and all the other ancillary department who have been very helpful for us to achieve and reach this landmark. Thank you so much.